بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. It is my pleasure today to speak to you about chest pain and chest pain approach. And we need to concentrate about chest pain because chest pain could be sometimes a sign of a very serious underlying disease. So I am going to share with you the screen about chest pain and how we can evaluate chest pain. Just to remind you that this PowerPoint presentation will be available for all of you after finishing the Zoom video interaction. So my name is Ihab Suleiman, and you know my email and my mobile, so I could send the presentation to you. So we need to talk about how we can approach a patient with chest pain. So the differential diagnosis of chest pain is many. If we started with the cardiac causes of chest pain could include myocardial infarction, pericarditis, myocarditis, and aortic stenosis. All these four causes could be important causes of chest pain. Pulmonary causes of chest pain include the most important cause is pulmonary embolism, but however, other causes like pneumothorax, asthma, and acute chest syndrome, which complicate sickle cell disease or sickle cell anemia, can also present with chest pain. Pleura could be causing chest pain like pleuritis or pneumothorax. Aorta is important because aorta can lead to aortic dissection or perforated aortic ulcer, and this can give rise to chest pain. Chest wall causes of chest pain could include costochondritis and other musculoskeletal causes of chest pain. Esophageal causes of chest pain could include esophageal spasm, eosinophilic esophagitis, esophageal rupture or perforation, or what is known as Boerhaave syndrome, gastroesophageal reflux disease, mediastinitis, and right upper quadrant pathology, as in gallbladder disease, can also present with chest pain. Important also to include psychological causes or neurotic causes like panic attack. Young people can present sometimes to the emergency room with chest pain if they are having panic attack. So patients with chest pain, where can we see them? We can see them in the primary care or in the emergency department. And it is important to exclude the serious cardiovascular diseases of chest pain. So what are the lethal causes of chest pain? The lethal causes of chest pain include 6 causes. The most important thing to consider always to rule in or rule out, especially for me as a cardiologist, is acute coronary syndrome. Acute aortic dissection type A is important also to be ruled in or ruled out, because those patients with acute aortic dissection type A, they need surgical intervention immediately. Every 1 hour passes of acute aortic dissection, mortality rises by 1%. Massive pulmonary embolism is important. Precardial tamponade, although in precardial tamponade, the patient might present with shortness of breath more than chest pain. Esophageal rupture, as in Boerhaave syndrome, usually the part of the esophagus that rupture is the lower part at the posterolateral region, because this is the most weak part of the esophagus. Tension pneumothorax is also an important cause of lethal causes of chest pain, and it should be drained immediately or decompression immediately, because otherwise the patient can die because of hemodynamic collapse. Whenever we see a patient with chest pain, please ask the patient to point towards the location or to the site of the pain. So you ask the patient to locate for you where he is having or he is feeling the chest pain. This is important because the character of the chest pain can give you an idea about whether it is a typical ischemic chest pain or atypical chest pain. So this table will characterize for us when we say it is typical. When we say it is typical, it is consistent with myocardial ischemia. And when we say it is atypical, it is against myocardial ischemia. So whenever we say it is typical for myocardial ischemia or cardiac cause, the chest pain is usually felt like discomfort or pressure-like, and the time duration minimum for the chest pain of this cardiac origin is more than 2 minutes. A chest pain that has been going on and off for a few seconds or continuous for days is unlikely to be cardiac. Usually the chest pain of cardiac cause is provoked by activity, exercise. Radiation to the jaw is important, and also the character of the pain that it does not change with respiration or position. And sometimes, or commonly, the chest pain of the cardiac origin is associated. I will just take a break here. Okay.
خلاص تمام.
Jamaa, I am sorry, I did not recognize I made a mistake, but Assalamu alaikum wa rahmatullah.
وعليكم السلام ورحمة الله
وبركاته. بسم الله الرحمن الرحيم. I hope you are all well. وأسأل الله العظيم رب العرش العظيم أن يرفع البلاء والوباء عن بلادنا وبلاد المسلمين والعالم أجمع. So approach to chest pain. We are going to talk about approach to chest pain, and please stop me if you want to say or comment about anything. So approach to chest pain. This PowerPoint presentation will be available to all of you. And
لا حد البنات كيف حكيت شوف
so approach to chest pain is important, and
فيكم
so are we okay? And I think I will message. So approach to chest pain. The PowerPoint presentation will be available to any of you if you wanted a copy of the presentation. So approach to chest pain is important, and let us start from the beginning. Chest pain differential diagnosis is long. It could comprise so many systems in the chest or upper abdomen, or even psychological or neurological. So cardiac causes of chest pain include myocardial infarction, pericarditis, myocarditis, and aortic stenosis. Pulmonary causes of chest pain could include pulmonary embolism, pneumothorax, asthma, COPD, and acute chest syndrome. Pleura causes of chest pain could include pleuritis or pneumothorax. Remember, pneumothorax is more commoner in smokers or patients with Marfan syndrome or prior history of pneumothorax. Aorta causes of chest pain include dissection, perforated aortic ulcer. Chest wall causes of chest pain include costochondritis, musculoskeletal. Esophageal causes of chest pain are many, but include esophageal spasm, eosinophilic esophagitis, esophageal rupture or perforation, or what is known as Boerhaave syndrome, and gastroesophageal reflux disease, mediastinitis, or right upper quadrant pathology, as in gallbladder disease. Remember, young people with panic attack in the emergency department can have chest pain. So it is important also to include patients with neurological or psychological disturbance in the differential diagnosis of chest pain. The epidemiology of chest pain could include visits to the primary care and to the emergency department. But it is important always, whenever we are called to see a patient with chest pain, to consider the 6 lethal causes of chest pain, either to rule in or rule out. So it is important to consider acute coronary syndrome, which include ST elevation myocardial infarction, non-STEMI myocardial infarction, acute aortic dissection type A, massive pulmonary embolism, precardial tamponade. Also in precardial tamponade, the presentation is usually shortness of breath rather than chest pain, esophageal rupture, and tension pneumothorax. Always, always, always is to ask the patient to point towards the location of the chest pain, because this will give you an idea about the cause of chest pain. And it is important to consider the character of the chest pain so as to differentiate whether the chest pain is typical for myocardial ischemia or atypical for myocardial ischemia. When we say typical for myocardial ischemia, it is consistent or it is expected to be felt or to be found in patients with myocardial ischemia. So the typical character of chest pain for myocardial ischemia is the feeling of discomfort or pressure. The time duration of the chest pain is more than 2 minutes. And in myocardial infarction, the chest pain duration could be more than 20 minutes. It is usually provoked by activity or exercise, as in angina or exertional angina. Radiation to the arms or jaw are important for typicality of the myocardial chest pain, and it does not change with respiration or position, and it is associated with diaphoresis or nausea. The chest pain of myocardial ischemia is usually relieved by rest or nitroglycerin, but in case of myocardial infarction, rest or nitroglycerin effect could be variable. The pain for atypical myocardial ischemia can be localized by one finger. That is the importance of asking the patient to locate for you the chest pain. Or the chest pain has been there for days. Or the chest pain is fleeting from one place to the other. And importantly, for the atypical chest pain, that the pain is reproduced by movement or palpation. So radiation to the right arm or shoulder increase the likelihood of myocardial ischemia by more than 4.7 times. And radiation to both arms or shoulders is more than 4 times. Exertional chest pain can increase the likelihood more than twice. So when you evaluate a patient with chest pain, you need to ask the nurse for the most current set of vital signs. You need to ask the nurse to get an EKG, and it is important to do the EKG within 10 minutes from the start of the chest pain. And you need to see the patient yourself, and you need to assess him. So once at bedside, you need to determine importantly if the patient is stable or unstable. Because if the patient is stable, you need maybe to take more history, do your physical exam, get the family member, get more history. Because if the patient is unstable, you might need to do an action which might include intubation, or you send the patient to the cath lab, or you might need to do decompression for a patient with tension pneumothorax. And you need to do a focused history and physical exam. You need to read and interpret the EKG, and you need to do that within 10 minutes. If there is a prior EKG in the system or in the best care, you need to have a look at it and to see if there is any ongoing chest pain or any new changes. And if the patient is unstable, you need to take further action or call for help, or you call your second on call or call the consultant. And of course, you will need to do a clinical event note. The focused physical exam for chest pain include importantly the vital signs, the tachycardia. Hypertension might go with aortic dissection or even with myocardial ischemia. Hypotension can go with any condition. Hypoxia might go with pulmonary embolism, so it is important to have a look at the vital signs. The patient who's having active chest pain might be holding his hand on the chest. JVP, carotid bruit are important. Examination of the chest for rales, wheezes, or decreased breath count is important. Cardiovascular system examination, new murmurs or S3 gallop is also important, or S4 gallop as in hypertensive heart disease. Abdomen exam is important for any abdominal tenderness as in aortic aneurysm or pulsatile mass. Extremities for edema, peripheral pulses. Rash on the chest wall is also important. So let us take a scenario of a 25-year-old lady who suddenly developed chest pain, but it is unilateral on the left side, and it is worse with breathing. So the chest pain is changing with breathing. Her vital signs is afebrile, heart rate is 120, so she is tachycardic. Blood pressure is maintained, but her oxygen saturation is down at 89% on 2 liters of oxygen. And her oxygen saturation was 95% room air this morning. So physical exam of case 1 shows that the young lady is in distress. She is using her accessory muscle of respiration. Her lungs, there are no rales or wheezes. And her heart exam showed that there is tachycardia. There is normal first heart sound, loud second heart sounds. There are no murmurs. Abdomen exam is soft, non-tender. Extremities are warm and they are well perfused. So this is a lady, young lady with respiratory distress. She's tachycardic and hypoxic. Most likely the cause of her chest pain is pulmonary embolism. So her labs shows that her CBC within normal limits. Her BMB is elevated, and BMB gets elevated with any pulmonary embolism because there is pressure on the right ventricle. Her D-dimer is positive, and her troponin is minimally elevated. So D-dimer, BMB, and troponin can get elevated with pulmonary embolism, but D-dimer is more important. And D-dimer sometimes can also get very high with aortic dissection. So D-dimer can be positive with acute coronary syndrome, can be positive with pulmonary embolism, can be positive with valve thrombosis or stuck valve, and also with pulmonary embolism. But in pulmonary embolism, it is usually more than 5 times or 10 times. If your suspicion for pulmonary embolism is high, you don't wait for D-dimer result. You do your CT, spiral CT, or pulmonary protocol spiral CT to diagnose the case. And you need to start the anticoagulation or the enoxaparin right away. So this is her ECG. Her ECG is showing sinus tachycardia and non-specific changes. And the most important ECG sign of pulmonary embolism is sinus tachycardia. Sometimes we found S1, prominent S in lead 1, and Q in lead 3, and T inversion in lead 3, and also T wave inversion in B2, V3, B4. This is especially in cases of massive pulmonary embolism. They are pathognomic for massive pulmonary embolism with RV strain, but it is not found in most of the cases. So in most of the cases of pulmonary embolism, we have sinus tachycardia. This is the chest X-ray. It's showing normal heart size and normal lung fields. Remember, there are 3 signs of pulmonary embolism on the chest X-ray. The first sign is a prominent hilus, which is called the Pala sign. The other sign of pulmonary embolism on chest radiology is the Hampton sign, which is a wedge infarction of the lung. And the third sign on X-ray of pulmonary embolism is Westermarck sign, which is oligemia of the lung, which is embolized by the pulmonary embolism. So Westermarck sign, which indicate loss of perfusion, Pala sign, which indicate prominent proximal part of the pulmonary artery, and Hampton sign, which indicate a wedge infarction of the pulmonary circulation. So as we have said initially, there could be the differential of chest pain you need to consider individually whenever you evaluate a patient with chest pain. In our case, we can take the modified Wells criteria to diagnose pulmonary embolism, and we take the point. And important with immobilization or post-surgery, the likelihood of pulmonary embolism increase. That is why post-orthopedic surgery of the lower limbs for 4 to 6 weeks, they give anticoagulation. Malignancy, as in case of gastrointestinal adenocarcinoma, this can also increase the risk of pulmonary embolism. So the interpretation of the Wells criteria, if the score is more than 6, this indicates that the likelihood of pulmonary embolism is high. If it is between 2 and 6, it is moderate. And if it is less than 2, it is low. And in case of interpretation more than moderate, you don't wait for D-dimer. You need to consider the patient as pulmonary embolism by starting the treatment and sending the patient for spiral CT or CT pulmonary artery. The good thing about D-dimer, it is very sensitive, but it is very non-specific. So patient post-surgery, it could be non-specific because it is going to be positive anyhow. So it is important to consider these. So it is good if the D-dimer is negative. If the D-dimer is negative, this is more in favor of excluding pulmonary embolism. Hypoxia on ABG is important. Sometimes you don't depend on the pulse oximetry, but you need to do arterial blood gas. AKG changes are the most important changes are non-specific or sinus tachycardia. VQ scan, we can use it sometimes in patients who are not fit or they have high creatinine or they have contrast allergy. So VQ scan for patient with contrast allergy or a patient who have high creatinine. And also lower leg ultrasound, sometimes it is not sensitive. The CT pulmonary embolism is very specific. So it has a specificity of 96% for CT pulmonary embolism protocol. So when we have a patient with pulmonary embolism, it is important to have a good line, at least 20 Gog peripheral IV line, or a central line should be administered to the patient. This is a CT pulmonary embolism protocol of a patient with saddle-shaped pulmonary embolism involving the pulmonary trunk, and you can see that there is a big filling defect like a saddle-shaped. This filling defect here, and this is the main pulmonary artery. This is the aorta. This is the superior vena cava. This is the sternum, and this is the vertebral column. So there is a big filling defect, and it is arrowed in the picture. So this is a patient with massive pulmonary embolism, saddle-shaped, and the patient needed to be started on treatment. Nowadays, according to the guidelines, if the patient is hypotensive or hemodynamically unstable, he should be thrombolized. But if the patient is not hemodynamically unstable and blood pressure is not down, you can give heparin or low molecular weight heparin or other treatment. So how you can approach patient with suspected pulmonary embolism? Usually, when it is probability is moderate or high, try to get the CT as soon as possible. So acute pulmonary embolism, the main approach, the management include stabilization, oxygen therapy, fibrinolytic therapy if the blood pressure is less than 90 systolic. The anticoagulation in cases of malignancy, low molecular weight heparin is preferred over oral anticoagulation. Sometimes if the patient GFR less than 30, we might give heparin. And sometimes if the patient had high risk of bleeding, we can put an IVC filter in patient who is moderate to high risk of pulmonary of bleeding. Important to start the anticoagulation while waiting for your investigation to be done in cases of pulmonary embolism. Pulmonary embolism with hypotension, we have two other options other than thrombolysis. So thrombolysis is the first step. Sometimes if you have the expertise, as we are now having a good expertise with interventional radiology in our institution in National Guard, we can do catheter-based thrombectomy through interventional radiology, or we can ask the cardiac surgeon or the thoracic surgeon to do an open surgical thrombectomy. So 3 options are available for a patient with massive pulmonary embolism with hypotension: thrombolysis, interventional radiology catheter-based thrombectomy, or surgical approach. Let us take another example of chest pain. 67 years old male with past medical history of hypertension, dyslipidemia, diabetes type 2, and coronary artery disease. He had percutaneous coronary intervention in 2017. Now he presents with new onset of chest pain of 2 hours duration. His chest pain is retrosternal on a grade of 1 to 10. His chest pain severity is 7 out of 10, and it is associated with nausea and diaphoresis. His vital signs showed a temperature of 37, heart rate is 108, so maybe he's tachycardic because he's in pain. His oxygen saturation is 93%. His general exam, he's having active chest pain and he's diaphoretic. He's having crackles at bilateral bases, and there are no additional sounds or murmurs, and the rest of the exam is normal. And his CBC, still his troponin I, the first set was normal. And what would you do for a patient with chest pain, which look like cardiac chest pain or myocardial ischemia chest pain? You need to have EKG and chest X-ray. So ECG, chest X-ray, troponin, sublingual nitroglycerin to be administered to the patient, and you need to give an aspirin, soluble or chewable. So this is his ECG of the patient who have most likely chest pain of a cardiac origin. As you can see that the patient having tachycardia, and they are regular B wave lead 2, where we see the B wave equally, and in V1, so there is B wave and the patient is having sinus tachycardia, maybe the heart rate is 110 or 120, and there is significant ST depression as in V5 and in V6. So this is a patient who is having myocardial ischemia. He is not STEMI, but it could be non-STEMI or unstable angina, waiting for the subsequent troponin. If his troponin is positive, we can call it non-STEMI. If his troponin I is negative, then we can call it unstable angina because of the ECG changes, which are myocardial ischemia of unstable angina. So what could the EKG in acute coronary syndrome show us? First, there could be ST elevation. There could be ST depression. There could be T-wave inversion. Sometimes a patient who is non-cardiac might have T-wave inversion, but with the development of new chest pain, his T-wave inversion might disappear. We call that pseudo-normalization. The patient could present with new left bundle branch block or right bundle branch block, but right bundle branch block is uncommon. Or the patient can present with Q waves, which has not been present from before. It is important to do a serial of EKG because sometimes initially the EKG is normal, as in 50% of the cases. So this is a table or a diagram to tell you about what we are now having as a cardiac enzymes to diagnose myocardial ischemia. So we are using now the 5th generation of cardiac troponin. Since 2007 or after 2007, we are using the 5th generation of high sensitive cardiac troponin. And the cardiac troponin, we can use troponin I or troponin T. Most of the hospitals in the kingdom are using troponin I. Troponin T is produced by Roche company, Roche Diagnostics. So you might only find few hospitals which have cardiac troponin. important in the management is to administer sublingual nitro, because this will relieve the chest pain. And you need to call the cath lab consultant if the patient is having active chest pain, especially if the patient is having a STEMI, or you activate the cath lab to proceed for primary PCI. And the patient should reach the cath lab within 90 minutes from arrival to the door of the emergency department, or should be reach the cath lab within 60 minutes from the time of ECG. So it is important to look for these two time interval. Less than 90 minutes from the door of the ER, and less than 60 minutes from the time of ECG to the cath lab. So this is another patient with chest pain and is having T-wave inversion. You can see that there is T-wave inversion in AVL and in V2, V3, V5, V6. So this could be subendocardial ischemia of the LAD. Sometimes we might find these ECG changes with metabolic causes, or with electrolyte disturbances, or with any subarachnoid hemorrhage. So you need to be broad-minded, or to consider other differential when you evaluate an abnormal ECG. What myocardial infarction definition we are using now? Since 2018, we are using the fourth universal definition of myocardial infarction. And the fourth universal definition of myocardial infarction is dividing myocardial infarction into 5 types. Type 1 is the patient that comes from home with myocardial infarction, and it is not secondary to septicemia or hypoxia. Type 2 is the type that now we found with COVID-19 patients. A patient with COVID-19 severe pneumonia, they could have minor elevation in troponin. Patients who are intubated with severe COVID pneumonia, the majority will show an elevated troponin. And the elevation of troponin is considered to be as part of the inflammatory response as we expect in patients with cytokine storm as in patients with COVID-19 pneumonia. And it is not due to direct invasion of the myocardium. And elevated troponin is considered like an elevated inflammatory marker, as you also find elevated ferritin level or elevated liver function test. So type 3 is a patient who is having an autopsy finding of a thrombus. So we call it type 3 myocardial infarction, or a patient who died suddenly. Patient type 4 myocardial infarction is a patient who have sustained myocardial infarction secondary to angioplasty. And type 5 myocardial infarction is a patient who have sustained myocardial infarction secondary to cardiac surgery. So if a patient went for cardiac surgery and after cardiac surgery his troponin I started to rise more than before surgery, we call that type 5 MI, and it should be within 48 hours from the procedure. We have new types of MI. There are 3 types or 4 types. Takotsubo syndrome, which occur in postmenopausal women, and MINOCA. MINOCA is myocardial infarction with no obstructive coronary artery disease. This is an entity of coronary artery disease. A patient comes in with myocardial infarction, but when we take him to the cath lab, we don't find an obstructive coronary lesion. And we call that myocardial infarction without or with no obstructive coronary artery disease. Chronic kidney disease, more and more we find that patient with chronic renal failure, and especially before dialysis, they can get elevation in troponin I, Also, patients with arrhythmia like atrial fibrillation, they can get elevation in troponin, and this sometimes could be considered as some kind of special myocardial infarction. And the list associated with troponin elevation is actually a long list, including heart failure, myocarditis, Takotsubo, any cardiac procedure like catheter ablation, electrophysiology catheter ablation. Defibrillation can elevate CK or CKMB more than troponin. But whatever defibrillation shock was given to the patient, CK and troponin can get rise, even if the patient was not having myocardial infarction, but he came with VTAC or ventricular fibrillation and he received DC shock. This will be reflected by an elevated cardiac CBK or cardiac CBKMB. Or if the patient is having trauma to the chest, this can also give rise to elevated troponin or cardiac enzymes. Other causes of elevation of troponin can include critically ill patient in ICU of any cause. So type 1 MI is the type of MI that we see frequently in the emergency department. A patient comes in with myocardial infarction. He comes from home, and we find that there is a rise or there is a fall of his cardiac troponin I or troponin T, if we are in a hospital doing troponin T. And there are symptoms of acute myocardial ischemia. We can also see ECG changes, which might include ST elevation or ST depression, or we might find pathological Q waves, which develop at least 6 hours, or we find an echo findings of a new or loss of viable myocardial function by echo or by any other imaging modality. When we take a patient with type 1 MI to the cath lab, we might find that there is a coronary thrombus, and this might indicate that the patient presented with real myocardial infarction. So this is type 1 MI. The pathophysiology of type 1 MI is plaque rupture or erosion with occlusive thrombus. And this will give rise to ST elevation myocardial infarction. The whole lumen is obstructed of the coronary artery. When the lumen is partially obstructed, this is we found in non-ST elevation myocardial infarction. So the pathophysiology is the same for STEMI or non-STEMI, but for STEMI, there is complete luminal obstruction, and in non-STEMI, there is no complete luminal obstruction. In unstable angina, there is no plaque rupture. There is only plaque which is comprising more than 3/4 of the lumen of the coronary artery. So the pathophysiology of angina, there is built up of plaques without plaque rupture or erosion. So this is the pathophysiology of angina. The pathophysiology of STEMI is plaque rupture and erosion and complete luminal obstruction. The pathophysiology of non-STEMI is plaque rupture or erosion with non-occlusive thrombus, and the lumen might be partially open. So let us take this example of a common ECG presentation of a patient coming with, as you can see that there are ST elevation in lead 2, lead 3, and AVF. And this is a patient who present with acute inferior STEMI with most likely RV infarction, because RV infarction complicate 1/3 of all inferior MI. So we need to be very cautious, or we need not to give those patients beta blockers. Beta blockers are contraindicated for those patients. You might give beta blockers after a few days if the patient went to the cath lab and his right coronary artery is open. But initially in the emergency department, you don't need to give beta blockers, or beta blockers are contraindicated. You need to give a lot of fluids. You need to give atropine. You need to give inotropes. And if you have the option, you might give atropine first, and then IV fluids, and then inotropes to stabilize the patient before sending him to the cath lab. So nitroglycerin is contraindicated in patients with inferior MI with right ventricular infarction. Other contraindication in cardiology for nitroglycerin, other than inferior MI, is patient with hypertrophic obstructive cardiomyopathy. You need to avoid nitroglycerin. And also patients with severe aortic stenosis, we need to avoid giving them nitroglycerin. Also patients who are hemodynamically unstable, you need to avoid giving them nitroglycerin, because nitroglycerin can make them worse, because it can make peripheral vasodilatation. Also, patients who are not telling, but they might be using phosphodiesterase type 5 inhibitors. And sometimes how you can tell, if the nurse comes to you and tells you, yeah, doctor, the patient blood pressure drops suddenly after we gave him sublingual nitro. So most likely the patient could be using phosphodiesterase type 5 inhibitors. Sometimes the patient blood pressure drop after nitro if he's if he's hypovolemic. Patients with myocardial infarction could be sometimes hypovolemic. If we give them a peripheral vasodilator or a venodilator like nitroglycerin, this can lead to hypotension or even shock. Let us take case 3. And case 3, you are called to admit a 65 years old man for an acute coronary syndrome rule out. Let us take more history. Mr. Q is a gentleman with a history of type 2 diabetes, non-alcoholic steatohepatitis. He had an old history of non-STEMI, elevation myocardial infarction, hypertension. So he has a history of hypertension, but he has severe retrosternal chest pain. And the pain the patient tells you is different from the chest pain of myocardial infarction he had before. And the chest pain radiated to the neck, and it began 3 hours ago, but it is still very severe. So you need to go and assess the patient in the emergency department. His vital signs, his temperature is 37, he's tachycardic because of the pain. His blood pressure is 145/80. His focused exam is within acceptable limits, but the blood pressure on the right side is 145/80, and on the left side is 110/60. Unequal blood pressure is commonly associated with severe atherosclerosis or sometimes aortic dissection. So remember, unequal blood pressure, more than 10 or 20 millimeters of mercury, you need to consider if the patient is having atherosclerosis or subclavian stenosis or aortic dissection. So this is the chest X-ray. As you can see that there is widened mediastinum. You can see that the part of the aorta shadow is widened, and this immediately with the history of chest pain and hypertension. And he tells you that the type of chest pain is different from the chest pain he had with myocardial infarction before. This will make you raise the suspicion of acute aortic dissection type A. And if you have a prior chest X-ray to compare, and this will give you a better insight for the myocardia, for the acute aortic dissection. Sometimes there is a calcium sign, as it has been shown here. The vascular rim of calcification might be changing its position, and we call it calcium sign. So calcium sign in patients who are elderly or widened mediastinum, these are the X-ray, simple X-ray changes of acute aortic dissection type A. Of course, when you do a CT scan, you can see the dissection of the thoracic aorta here, or you can see the dissection of the ascending aorta here. So you can do a CT angiography, which is the standard nowadays in our hospital for acute aortic dissection. The CT is more helpful than the TEE because the CT for dissection, other than the diagnosis of dissection, will tell the cardiac surgeon where exactly the dissection started and where the dissection ended. So the dissection might be starting in the thoracic aorta and continued down for the whole abdominal aorta. The cardiac surgeon would like to know where is the start point for dissection because he will ligate it, and he needs to see where it ends because this is important for him if he would like to do further surgical technique. The most important risk factor for aortic dissection is hypertension. So patient with neglected hypertension or patient with a history of hypertension are more likely to suffer dissection more than other patients. But not only hypertension, but atherosclerosis, aneurysm, as you see it in patients with Marfan syndrome and other collagen disorder, patient with bicuspid aortic valve, patient with coarctation, patient with Turner syndrome. I remember when I take the MRCP endocrinology board exam, they ask us about what is the cause of death in patients with Turner syndrome. So the cause of death of patient with Turner syndrome is aortic complication as in dissection. 2% of patients with Turner syndrome will die eventually because of aortic dissection. And patients who have a history of CABG or any procedure on the aorta or in the heart, like aortic valve replacement, cardiac catheterization, these also can increase the susceptibility for dissection. And remember, high intensity weight lifting can also cause aortic dissection for susceptible subject with weak media and cocaine use, because this will lead to severe hypertension suddenly, and also trauma, direct trauma to the aorta can lead to dissection. So we have two types of dissection. We call it Stanford classification. If the dissection is starting and involving the thoracic aorta, as you can see the figure 1 here, we call it type A. If the dissection is started distal to the left subclavian artery, we call it type B. So type A and type B. Type A should go for surgery. Type B should go for medical treatment or blood pressure control. But if type B, the patient pain did not subside, he have further complication or further dissection, type B can go to surgery as well. So type A, the management is always surgical. Type B is usually medical, but the patient can be needing surgical intervention if his abdominal pain or chest pain continued or if his dissection started to expand. So type A is surgery, and you need to start beta blockers, labetalol, because labetalol can decrease the blood pressure and decrease the heart rate. And if labetalol did not control the blood pressure in type A, you need to add nitroprusside, and you need to have a must, or it is always an arterial line, because arterial line will give you idea about the blood pressure. Type B, the management is usually medical with beta blockers and nitroprusside. But again, surgery for type B is for those with end organ damage or those who don't respond to medical therapy. So this is how you can manage patient with acute aortic dissection, and how you can manage him well. So let us take case 4 of a chest pain, 53 years old male. This might be the last case. So 53 years old male with chest pain and EKG abnormality. He has a past medical history of hypertension and dyslipidemia. And you go and see the patient and he tells you that he has chest pain for 2 days and it is getting now progressively worse. His chest pain is now worse with breathing, and he had a recent viral upper respiratory tract infection. So the history is suggestive of something not going with myocardial ischemia or acute dissection. So this is our patient. His vital signs, his temperature is a little bit elevated, 37.9, heart rate is 104. Typically, this patient, if he presents these days to any emergency department, not even in the Kingdom of Saudi Arabia or anywhere in the world, he might be considered a patient with suspected COVID-19 pneumonia, because he has some kind of fever, atypical chest pain, and he has some shortness of breath. His physical exam showed mild distress. His lungs are clear. And his heart is tachycardic. His white cell count is elevated. And his other laboratory markers are normal. His acute myocardial infarction panel is negative, and his chest X-ray is negative. This is his ECG, and his ECG is showing diffuse ST elevation involving most of the leads, and there is PR segment elevation in AVR. So there is ST elevation in most of the leads, and there is PR segment elevation in AVR. He is tachycardic, he's a little bit febrile, he has a recent upper respiratory tract infection. So this is all together, and his cardiac troponin I is negative, although sometimes it might be positive in cases of acute pericarditis or acute myopericarditis. So the patient is most likely having acute pericarditis, which is indicating inflammation of the pericardial sac. And the most likely cause of acute pericarditis is Coxsackie virus. You might get that question in USMLE, Coxsackie A, Coxsackie B, might be, or any other echovirus or adenovirus. Typically, patients with acute pericarditis, they have sharp pleuritic chest pain, and their chest pain is relieved by sitting up or leaning forward. The etiology of pericarditis is actually, the etiology of pericarditis is huge, but for the sake of exam, USMLE, Coxsackie A and Coxsackie B are the most important cause. In the past, before the era of antibiotics, bacterial causes of acute pericarditis are also encountered. And sometimes you might find acute pericarditis with uremia, Acute myocardial infarction can cause acute pericarditis from the second or third day, or sometimes we find it complicating acute myocardial infarction or myocardial surgery after 2 weeks. We call that the Dressler syndrome. Malignancy, radiation can also cause acute pericarditis, especially if you have a left breast pathology. Ladies with left breast pathology or left breast cancer, they suffer more damage to the heart than those with right breast cancer, unfortunately, because the heart is located more towards the left side. Autoimmune disease like SLE, they can present with acute pericarditis, and only in those conditions, steroids are allowed as a first line. Otherwise, you don't give steroid for any simple acute pericarditis. Drug-induced SLE like hydralazine or procainamide can also cause drug-induced SLE or acute pericarditis. So these are the differential diagnoses between acute pericarditis, acute myocardial infarction, and early repolarization. Remember, in the emergency room, if you are not sure whether you are dealing with acute pericarditis, acute MI, or early repolarization, you need to take the patient to the cath lab. Even if you are almost confident, but any doubt about a patient, whether he's having acute pericarditis or acute MI, the best thing is to take the patient to the cath lab. If the patient is having acute pericarditis and he went to the cath lab and he has normal coronaries, no harm has been done to the patient. If the patient with acute myocardial infarction was treated as acute pericarditis, this will lead to complication. So it is important to consider those. So how you diagnose acute pericarditis? Clinically, you should have 2 out of 4 criteria. You should have typical chest pain. You should have typical chest pain of acute pericarditis, as we have already mentioned. Or ECG changes like widespread ST elevation, or new or worsening pericardial effusion. So should we have 2 criteria out of 4 to diagnose acute pericarditis as up to date in 2012? What are the high-risk features for acute pericarditis? If the patient is having fever or leukocytosis, or he's having evidence of pericardial tamponade, or he is immunosuppressed, or he has a history of ongoing therapy with warfarin, or he's having acute trauma, or a patient who has come before to the emergency department and he was given non-steroidal anti-inflammatory drugs, but it did not relieve his chest pain. Also, patients with positive troponin, if they are having acute pericarditis, they should be admitted to the hospital because they are considered high-risk patients and they might develop severe myocarditis and they might need supportive therapy like ECMO or other treatment. What is the treatment of acute pericarditis? So the acute pericarditis nowadays, we can treat it with non-steroidal anti-inflammatory or colchicine and aspirin. I am talking about simple acute pericarditis. I am not talking about acute pericarditis post-MI. Post-MI, the only allowed drug is aspirin, but aspirin in high dose. So acute pericarditis for young patients, you might give non-steroidal anti-inflammatory, you might give colchicine. Colchicine has been proven also to be anti-anginal, so you can give it to patients with coronary artery disease. And you might give aspirin, but you need to give a dose of 2 to 4 grams a day in divided doses. And you need to treat the acute pericarditis for 1 to 2 weeks, or until the patient's symptoms subside. Patients who need to receive steroid are called refractory. So patients who are refractory or they are having SLE-associated acute pericarditis, they might be given prednisolone. If patient with acute pericarditis, they have positive positive troponin or positive myocardial markers, they needed to be admitted to the hospital and be in ICU for a few days and get a serial of echo because sometimes they might develop fulminant myocarditis and they might need immunoglobulins, they might need steroids, they might need ECMO, extracorporeal membrane oxygenation. I think we can stop here and we can make a plan. Tomorrow we can discuss ECG cases and we can complete case 5. And thank you very much for your attendance. And if you need the presentation as I have shown you, you can know how to get me, so I can send it to you by email. So this is my mobile. This is my mobile and this is my Gmail account. So you can call me or send to me, and you are all more than welcome. I think tomorrow at 9 o'clock after Isha prayer, we can also talk about the rest of the chest pain scenario and also about ECG interpretation or ECG cases. Thank you very much.